The patients get oxaliplatin and they play a guitar, or they're a diabetic and already have neuropathy. Maybe their medication or their treatment plan would be tailored differently, all to improve their quality of life. Don't discount sexuality and intimacy and fertility in any of your patients.
That's really a good point. We've tried to normalize that a lot, but definitely is something that can be overlooked and is very, very important.
One of the biggest survivorship considerations to me is to understand that patients want the cure and they don't always understand what chronic disease means.
You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS. And today we are joined by ONS member Ilene Comeras Lattimer, Clinical Research Specialist at James Cancer Hospital and Solove Research Institute in Columbus, Ohio, and Director at Large of the Columbus ONS Chapter, to discuss how nurses can navigate patients with metastatic colorectal cancer through treatment and survivorship. Pfizer provided support for this podcast episode through an educational grant. A few weeks ago, we had ONS member Chris Mathney, a gastrointestinal medical oncology nurse practitioner, on to discuss treatment options for this diagnosis, and we included a link to that conversation in the episode notes. ONS will be launching NCPD videos and case studies as part of the scope of this project. Thanks for joining me today, Ilene.
Thank you for inviting me.
So to start us off, tell us about your experience in caring for patients with colorectal cancer.
Well, I come by it honestly and personally as well as professionally. Since about 1999, I've worked with clinical research in colon cancer and hereditary research projects where we discovered universal screening for Lynch syndrome. My family also has Lynch syndrome, so my experience, like I said, is both personal and professional. I understand the whole spectrum of identifying with the caregiver and the patient, as well as identifying risk and prevention and survivorship. In addition, I facilitated colon and GI support groups at the James for many years, initiated by a grant from ONS to start one of these support groups. And I also coordinate conferences that focus on colon cancer awareness and screening and survivorship. I have a personal belief that listening to patients and caregivers was the most valuable part of my nursing career in discovering just what survivorship actually means to the patient. And discovering the many survivorship programs that they used and what benefited them most is what's the most valuable thing as a nurse.
Well, thank you for that. And from what you said, then you definitely have a lot of experience with this area. So I can see why you've had such a passion for this diagnosis. So Chris Mathney went over this in detail last time on our other episode, but can you remind us of the advancements in treatment options for patients with metastatic colorectal cancer in the past 5 years?
Yes, Chris did an excellent job. And some of her key takeaways were that while most patients with metastatic colorectal cancer are incurable, there's hope. Metastatic colorectal cancer is treatable. Treatment has improved survival outcomes with new advanced treatment options. And if there can be a cure, if surgery is an appropriate choice of treatment, the systemic therapy continues to be the mainstay for these patients, as well as what's been exciting to me is the personalized medicine approach of genomic profiling, where it specifically tailors the treatment based on the molecular and pathological features, and the multidisciplinary approach and evaluation. Those are key And those have been extremely instrumental advances in, especially in the last 5 years, in survivorship outcomes.
So today we are talking about kind of navigating patients through this journey that they're on when they have this diagnosis. So, as you just mentioned, the updated treatment options for these patients, and with these treatment options, like many other cancer treatments, there are adverse events that are associated with those treatments. So can you kind of help tell our listeners today, what are those key adverse events that nurses need to know about, and how can we as nurses help patients navigate those challenges?
So I think the biggest thing as an oncology nurse is you must keep up. You must keep taking conferences and reading and learning what these advances are and these new treatments. There's different surgical interventions, radiation, systemic chemotherapy, and immunotherapy, targeted therapies. It makes our head spin, but we have to keep up because patients keep up, especially as they're going through it. And chemotherapy has a potential to cause a wide variety of side effects. If we don't know them as nurses, we can't teach the patient on how best to manage them at home to prevent severe side effects and delay treatments. And chemotherapy, targeted therapy, radiation, surgery, they all have different side effects for us to manage. And I think one of the key things is where most of the patients are on combination treatment. They may have had surgery and radiation, then they're going to get chemotherapy with a targeted therapy or immunotherapy. You have to take these side effects as a whole, not as a silo of just chemotherapy or targeted therapy or surgery. You have to have a holistic sort of approach to symptom management. Some key points in symptom management is that clinicians must tailor their survivorship plan as an individual, much like they're doing for their tumor profiling. Everything has to be taken specifically and personalized for the patient. Nursing assessment should include identifying the risk, the factors that the patient may come to the hospital with or come to your clinic with, like diabetes, or they maybe already have some peripheral neuropathy, or they may already have heart disease, or they may already have bowel problems like irritable bowel. And they may already have some psychosocial issues. So assessment of these risk factors and physical and psychosocial measures is a continuous process and very necessary to have a baseline as well as ongoing. Identifying patient education, and especially how can they monitor this at home and how best should they communicate it to the providers, is very important to promote adherence, prevent adverse events and hospitalizations, and therefore a whole host of other things like cost. Effective communication and education is essential. Not every patient is going to be able to communicate in the same manner or prefers to be a certain manner of communication. And it's also good to remember to provide handouts in their appropriate language and do follow-ups. There's lots of literature saying that they improved compliance based on follow-up assessments and reminder calls at home. And oncology nurses, I think we need to realize that this is a lifelong process for patients from diagnosis through end of life. Even though they may not be curable, they do have improved outcomes. So we need to be cognizant of that and provide that to them. And another important reminder is evidence supports palliative care should be initiated as soon as possible. Early palliative care intervention has been shown to improve overall quality of life, especially for advanced cancer patients, and also to improve communication. Educating the patients may prevent also, as I mentioned before, progressing to severe side effects. And treatment depends on their pre-existing conditions, as I mentioned too. Then the biggest thing as oncology nurses is utilizing evidence-based assessment and management tools, which ONS, the ACS, and NCCN guidelines and recommendations are excellent. We can't know everything, but we can follow these, and they're wonderful guidelines. Patients may experience an increase in distress at different times of their survivorship, like initial diagnosis, any time of progression or transition to the end of life. And I think that's another thing we have to recognize and tailor our survivorship to those distressful times. One of the most common and distressing side effects is chemo-induced nausea and vomiting. There are very good tools. There's a tool actually that combines the emetogenic risk with the individual risk factors that a patient may have. So that's an excellent resource with a multinational association of supportive care tool. And then there's a clinical practice tool to assist patients, which is the MASCC anti-emesis tool, to assist patients in assessing and reporting nausea and vomiting symptoms to their oncology providers. And also for the nurses to recognize that chemotherapy treatments that are standard for metastatic colorectal cancer, like Fulvox and Fulfuri, is considered moderately emetogenic. But when you have somebody who's getting combination treatment, you have to realize that, and then you take the treatment for nausea and vomiting, you take the highest effect and treat accordingly that way. There are certain guidelines, and a lot of these guidelines are already spelled out in the video that I think you'll be provided a link for symptom management. So I don't want to go over all of it, but know that there are different guidelines for the different types of treatment, like chemotherapy and the checkpoint inhibitors, where they may be adding something like dexamethasone for checkpoint inhibitors as an antiemetic. That's according to ASCO. And then usually using just, again, taking things in a silo, not just their chemotherapy or their targeted therapy, but checkpoint therapies, but looking at them as a whole and treating it as a whole. Diarrhea is another debilitating side effect, and patients may present with that beforehand, and from perhaps disease like irritable bowel, or it can be added effect with their chemotherapy and their targeted therapy. Surgery and radiation, if they've had combination treatment there, that may impact their bowel function as well, and especially if they require a temporary or permanent ostomy. Treatment for diarrhea, immunotherapy-related diarrhea, is different than chemotherapy and targeted therapies. So this is taken all into account too. The NCCN and ONS resources have clinical guidelines to support this management of adverse events and diarrhea and how you treat those. And those are all outlined in that previous video too. And also don't forget that when they do have diarrhea, just don't assume that it's from, a certain treatment. Make sure you do stool studies so you're giving them the correct treatment. Make sure it's not from C. diff. That's a big thing for nurses to consider too, is to do the stool testing and make sure you're treating the right thing. Immunotherapy treatment for diarrhea, like we said, is different. And there are guidelines and different treatment where corticosteroids are offered based on what is causing the diarrhea. Constipation is another problem with some of the treatment. Identifying the patient's disease burden or any adhesions or lifestyle, maybe their medications that they're taking, like their opioid use for pain, may also present itself as the constipation. And there's different ONS issued guidelines for opioid-induced and non-opioid-related cancer constipation to guide as we care for our advanced cancer patients. The guidelines also recommend the patient should be educated about lifestyle factors that can minimize the risk, including water and fiber, and putting them on a prophylactic bowel regime if it's a known they will experience constipation in their lifetime or during their treatment. Chemo-induced peripheral neuropathy is another debilitating side effect that sort of stops patients in their tracks at times. And just a reminder for nurses that peripheral neuropathy affects sensory and motor nerves. And there's really no medication that's recommended for the prevention of chemo-induced peripheral neuropathy. There is a medication, like Cymbalta, that's recommended for painful when it becomes so painful and it affects their quality of life. And there's some other things that they can try with, whether it's physical therapy, relaxation, guided imaging, things like that. It's really debilitating to some patients where they have a hard time walking or picking up things, and it really affects their quality of life. So anything that we can do is helpful. And at-home management should focus on monitoring the severity and potential progression, as well as maintaining safety for patients. I know a lot of times we tell patients, well, it may go away after you've stopped your chemo, or we can reduce your dose. There's a lot of other things we can try. So then when it doesn't all go away, the patients get kind of upset. And that's one of the things the patients mentioned in support groups. Like, they said it would go away when I stopped chemo, and it hasn't. So just a reminder, we try our best, and, you never know if it's going to continue or not. But trying to help patients through that side effect is very, very much appreciated on their part. Mucositis is another side effect with our chemotherapy drugs. There are some things that help with that. And again, this stuff is outlined in the first video. I want to remind people that referring patients to nutrition services is very helpful. They can give them a lot of guidelines on how to help with the mucositis, other than things that they may get, like basic oral care, using a toothbrush, mouthwashes, and avoiding irritating foods and things like that. One of the biggest things that the nutrition specialist spoke at one of our support groups was try adding things like olive oil to your food to help you swallow easier. And patients felt that was very helpful. But there are guidelines to use. Another reminder is that some medications were the recommendations were against using, like the sucralfate and chlorhexidine. They're against. So look at your guidelines, because they're always updated, and get the best evidence-based guidelines on theirs. And there's a toolkit on that too, the multinational MASCC on supportive care. And and ONS PEP cards too. They all have great evidence-based treatment and suggestions based on current evidence. One of the other things that can be part of skin toxicities is your EGFR and targeted therapies, bevacizumab, cetuximab. At least 90% of the patients that are taking an anti-EGFR will experience a dermatological toxicity. And a lot of times they'll get this rash on their face and their chest, which can lead to infections and very painful. There is a tool guide, the skin toxicity evaluation protocol, that they can use. They may try things as antibiotic creams and to try and limit it and prevent it from getting into an infection. And one of the things patients talk about also in the support group is they say, well, how come they say that having this is a good thing? And it's hard to understand, how can this rash, this painful rash, be a good thing? But we remind them that people with the rash, it does mean that they're responding to treatment and providing some relief. Then it might be a benefit in survival. And then they seem to understand it a little bit, and it helps them tolerate it a little bit more. And just letting them know there is treatment, and to keep communicating with us. When does it become so painful that it's really disrupting your quality of life? When is it infectious that you would need an oral antibiotic? So using things like don't use perfumes, and don't use hard soaps with alcohol and creams and stuff like that is very beneficial too to them. And again, I don't want to go over too much of that because that's already in the video. Fatigue is the next thing. And I think that the patients complain most about the fatigue before and after and during treatment. Cancer-related fatigue is so distressing to them. And so they need to be reminded that they need to rest and also take naps. And oddly enough, to remind a patient that yoga and also exercise can actually help patients through there. Fatigue also can be related to other cluster of symptoms, such as pain, depression, and sleep disturbance. So nurses need to be reminded of that too for patients and to remind them that it's not just fatigue in a silo, it's fatigue can cause a whole gamut of symptoms in the patient. It can make their pain worse, their depression worse, and it can affect all aspects of their quality of life. And just letting them know when to tell their healthcare provider, and if your fatigue is just so bad that they really can't handle it, or they're not eating and not exercising and not getting out of bed. I don't think you can ever underestimate the emotional or anxiety or depression side effects of any medication. So when you talk to a patient, I feel that nurses need to start that conversation, because sometimes they don't realize that, and they don't want to bring that up. But identifying the treatment and anxiety of depression can be so many different things, and there's a lot of different strategies, pharmaceutical and non-pharmacological, that they can use. And just being aware of it, patients need to know that it's okay to ask for an antidepressant or medication to help with anxiety. Sometimes they're really hard to ask for that, but I think we as nurses need to ask that question and bring it up. Like, how are you doing with this? There's also a distress screening tool, which is recommended by the NCCN. And that's also a very good tool to use with the patient, so that sometimes they can look at this and say, okay, this is moderate or significant. Maybe we should refer you to a social worker or counseling, or maybe a specialist like a psychiatrist, so they can really help you with interventions. But I think bringing up that conversation, it really helps patients. They're afraid to talk about some things, especially when you're talking about their sexuality or even their spirituality. They're afraid to bring it up. And I think us being very open about that and bringing up that conversation really help. And one last point with any side effect, again, it's all outlined in our video with this group talking about metastatic colorectal cancer. Assessment is so important to consider the patient's individual lifestyle, medical history, and side effects of these treatments. Where did they come from? What do they do? If the patient's getting oxaliplatin and they play a guitar, or they're a diabetic and already have neuropathy, maybe their medication or their treatment plan would be tailored differently for them, all to improve the quality of life.
Well, thank you for going over some of those key adverse events for us that would be related to systemic treatment that these patients get. So talking about one of the other treatments that this patient population may experience is surgery. So what do nurses need to consider when helping patients navigate recovery for surgery?
So I think with realizing, again, their pre-existing conditions and helping them, the impact of it may change your bowel function, and they may potentially require a temporary or permanent ostomy, and it may make them predisposed more to nausea and vomiting, diarrhea or constipation, and might impact their nutrition greatly. It also is which they have to recover from the surgery before they can start treatment. Patients have a hard time with that concept. They want treated right away. They want to get rid of this. And when you say, well, we can't start treatment for 4 to 6 weeks after your surgery, sometimes patients are upset with that. But just being transparent about everything and letting them know we're going to help you through all of this.
Those are good things to think about and to know with their treatments. So what additional training or education do oncology nurses need to help patients navigate this diagnosis?
I just can't say enough about oncology nurses being up to date. Things are changing so rapidly. So looking at the ONS podcasts and resources and guidelines, obtaining your oncology nursing recertification course and competency, conferences and networking. Networking is so powerful. We talk to another nurse from another area, another town, another state, another country, like what works? What have you guys found out that works? Utilizing the toolkits. Oncology nurses working with their providers to help patients make their decisions and So you know the best about patient treatment, so you can help them make good decisions. But I can't, I can't express enough your competency courses through ONS. It really helps you keep up with the latest treatments and symptom management.
You're so right. Treatments are changing so rapidly, and new options are happening so frequently, and it is very, very important to stay up to date. And all of those resources that you mentioned are great ways to do that. So, you've talked about a lot of the treatment advances that are happening, and with treatment advances, more often than not, we see increased life expectancy and better patient outcomes with the advances in treatment. And, when we're looking at personalized medicine and immunotherapies that are targeted for specific variations in genes and different things like that. So now that they're having a increased life expectancy, we're now talking about survivorship. So what are some new survivorship considerations that nurses would need to address with their patients?
One of the biggest survivorship considerations to me is to understand that patients want the cure and they don't always understand what chronic disease means. And so letting them know about their survivorship programs, and we have improved screening, diagnosis, and treatments. And having a chronic disease is not a bad thing. And just nurses being aware and having the knowledge regarding long-term care, late effects, prevention of new or current cancers, and their increased risk for other cancers and need for surveillance. If you as a nurse understand this, then it's going to help you to have the patient understand. It's going to help you teach them. And identifying that patients who do have this chronic cancer diagnosis and treatment, it can be intense for the rest of their life. And they could benefit from a unique, personalized model of survivorship plan for them, and multidisciplinary, that you're bringing in everybody to help them and teach them and talk them about surveillance and prevention. A lot of patients would feel, and I think a lot of nurses feel like, oh, they don't need surveillance. This is a chronic thing, or that there's maybe no cure, but they do. They still need to manage their bowel disorders, their fatigue, peripheral neuropathy. They still need to have screening so they can prevent and catch other things early. Sometimes, patients feel, and nurses would feel like, well, they've already got one cancer. We're just going to focus on that. You need to focus still on the whole person and identifying what other health style and behavioral counseling they may need, and periodic surveillance and prevention of other diseases. And so it's really important to have that no matter what their life expectancy is. So survivorship considerations is an ongoing assessment and ongoing identification of appropriate resources for them.
So we've talked a lot about, the treatments and survivorship. And one thing that does come up with all of our cancer patients in different diagnoses is sexuality and fertility. So how do treatment options or the diagnosis influence that with this patient population?
This is such an important question, because patients, again, sometimes don't want to bring this up. And I feel like nurses, we have to start that conversation. And also, nurses need to understand sexuality and intimacy are different. And it doesn't matter what age you are or what your sexual preferences are, and not to assume anything. Like, don't assume that they're older and they don't want to talk about sexuality or intimacy, or it doesn't matter to them, because it very well does matter to them. That's part of their quality of life. The same thing with sperm and ovary sparing procedures. Don't assume just because they have different sexual preferences or they're older that they don't need that discussion either. I had a patient who had a same-sex partner, and the nurse actually came in and talked to him and his husband about sperm sparing for children. And that wasn't on their plate at all, thinking about it. They were thinking about how can we be intimate and have sexuality when I'm going to have all this bowel reconstruction. So, and I think and the other thing is another patient comes to mind where they were older, and I want to say older, they were in their 40s. And sometimes we can assume that they don't care about having kids at that age. I don't think we can assume. We need to start that conversation and ask them how we can help them with their sexuality and intimacy and any sperm or ovarian sparing procedures that they may be interested in. But don't discount sexuality and intimacy and fertility in any of your patients.
That's really a good point. I think it's something that gets, overlooked, and we've tried to normalize that a lot, but definitely is something that can be overlooked and is very, very important. So we've talked a lot about the physical adverse events that come with this diagnosis, but there's another, adverse event or something, a burden that patients have, that isn't, physical, but it's the financial burden for many patients. So that's something that we as oncology nurses also need to consider. And can you talk a little bit about how nurses can support patients through those economic hardships?
Sure. Again, starting that conversation, a lot of patients and families may feel embarrassed about talking about the fact that they can't afford this, or how are they going to afford this? Some patients feel that, am I going to have to sell my house? And those type of things. So to ease that pain of that financial burden for them, start that conversation, empathize with them and say, hey, we have help. We can contact you with a financial consultant, and we have resources. There's financial support for copay and support. Pharmaceutical supply companies have. If you don't have insurance, they're not going to say, hey, we're not going to give you our product. We have help. And the social workers can help facilitate that too. And your financial consult through your survivorship clinic is very valuable.
Great points. Thank you. So another piece that I think is really important that we talk about with our patients and families is how do we navigate the advanced care planning discussion, talking about goals of care and also bringing in palliative care and from, the beginning. So what advice do you have for nurses for that?
I think and when we see a patient for the first couple times in clinic, these type of services need to be offered and talked about. Palliative care, the ONS, the American Cancer Survivorship Guidelines. So sometimes in our clinic, they get a folder, and it's usually, this is folder with all these resources in there, and their head's already spinning around. So giving them this folder and say, hey, in the future, let's talk about all these things that can help you navigate through your treatment. And you want to talk to somebody about making advanced care decisions and about getting some of your written directives down. Do you want to talk to somebody today, or do you want to do it at your next visit? But don't discount it. Don't have it there for them, and offer a time that you can explain it more formally. And one thing in the support groups, patients would say, oh, I just really think it's disgusting when somebody brings this up. And my first couple appointments. So we try and let them know that we want to make sure that you're aware of this and that it's a necessary part of everybody's life to do advanced care planning and have those discussions. And there are guidelines, and there's help available here with our social workers, and help them navigate through that. And it may not be their first couple visits, but sometime soon. Especially palliative care, patients think that you think I'm dying if you're taking me to palliative care. And just giving them information on what is palliative care and what can it provide for you. And it can provide a lot of support for you. And that's just what we call our department that provides a lot of that support for you.
So what are some common misconceptions about metastatic colorectal cancer?
So I think a big one is that it's not a death sentence. There are advanced treatments and improved outcomes, and we can improve your quality of life and talk about that it's a chronic disease. and we're going to try our best. And recognizing that distress does play a huge part in symptom management, and distress screening is important to help them through that. Survivorship and support groups. Another misconception is older patients, and I've had people tell me this when I did the chemo class, that says older patients don't need discussions regarding sexuality and intimacy, and younger patients don't need fertility discussion, and especially if they have same-sex partners or have different cultures. And I think the biggest misconception is don't assume that somebody thinks the way you do. We need to start that conversation and ask them, what is quality of life to you? And bring up these key points about sexuality, intimacy, financial burden, and that kind of stuff. And also a lot of misconception about metastatic patients don't need surveillance and health behavior changes. It's never too late to do healthy behavioral changes and to make sure you're getting the right surveillance and screening. Patients who've had treatment like chemotherapy, radiation, need screening for other cancers that may come up with the radiation, such as with radiation. If they have radiation to the abdomen, it may have put them at an increased risk for another cancer.
So what's something about metastatic colorectal cancer that's not often discussed, but you wish people knew more about?
I mentioned here the survivorship and palliative care consults. Our survivorship consults are so comprehensive. They include, nutrition, financial, all kinds of palliative and survivorship issues. And they also include nutrition, genetics. And survivorship means so much more than a lot of people, I think, realize, a lot of nurses realize.
Thank you. Ilene, this has been such a great podcast today, and just the information that you've been able to provide for our listeners has been wonderful and just so informative. And I want to thank you for your time today. But as we finish up, do you have any final comments for us?
Be a great listener and learn from your patients and your caregivers, because that's part of improving quality of life for all patients too.
Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.